Hello everyone. So I'm just going to give people a couple of minutes to filter in. This is week 3 of my Instagram live series where I'm talking about post-traumatic stress disorder, PTSD. So again, just waiting a couple of minutes for people to filter in. So before I get into today's topic, complex PTSD, I want to add something that I don't think I emphasized enough in the last 2 weeks. One is, I'm just looking at some stuff here. One is that I've really emphasized the anxiety aspect of post-traumatic stress disorder, but it's not so much anxiety as it is an overactivation of your fight or flight sympathetic nervous system. So I use the analogy of if you come across a bear in the woods, your body releases stress hormones, adrenaline, noradrenaline, and that's to help you fight or flight, escape, fight the bear, most likely try to escape. And so it's a very evolutionarily adaptive response, but the problem is in post-traumatic stress disorder, it misfires in situations where you're safe. So anyway, I emphasize the anxiety part, but the fight part is also a really strong manifestation for a lot of people. So I see it a lot, for example, in veterans, people who've been in combat, where they were kind of trained that when they're in that high sympathetic nervous system state, they pursue, they fight. So what will happen is that they'll get in this state and they'll have road rage incidents or get into bar fights, a lot of anger problems. Sometimes people have really extreme mood swings, be more irritable than they normally are. So that extreme anger, extreme irritability is another emotional manifestation of the fight or flight response. So I just wanted to add that to what I don't think I emphasized enough in the past couple of weeks. So anyway, I'm going to hop into today's topic, which is complex PTSD. And I got the idea to talk about this because I got emailed a question about it. And so I'm going to just go over what is that and what does it mean and how do you know if you have it as opposed to like regular PTSD, and how is it treated differently if it is treated differently. So to start off, this is really more of it's kind of controversial if complex PTSD or CPTSD is its own distinct thing separate from regular PTSD, meaning that it only really matters to separate it if the treatment is different, and it's not quite clear that from a research standpoint that they're so different that you need to call them different things, which is why complex PTSD is not specified in the DSM, the Diagnostic and Statistical Manual, which is the diagnostic manual for psychiatry, although in the World Health Organization's ICD-12, it's just their own diagnostic categories that will be coming out. They are going to be having a specific term for complex PTSD. But long story short, the idea is it could just be regular PTSD, but a severe form, So the difference is, imagine someone who essentially has a pretty normal, as any of us do, childhood, early adulthood, adolescence, and then one really bad thing happens to them, like an assault or a rape or a natural disaster or something like that, and they develop PTSD. That's a very different thing from someone who was, say, repeatedly abused over the course of their childhood. And even if their trauma started in adulthood, take, for example, surviving cancer or a prolonged medical illness that people often suffer from for years, that can lead to complex PTSD where it's not just a single trauma, but like repeated over time. So like people getting kidnapped and tortured or childhood abuse. And when the trauma happens in childhood, it can cause a whole other level of problems because the person is essentially denied the opportunity to have a normal emotional development where they feel like a sense of safety from their parents or caregivers. And it's not just, sometimes unfortunately it's the parents perpetuating it, but even if it's not, there can be a feeling of like, wait, my parents should have protected me. And it leads someone to not develop like a sense of, just to ever develop a sense of safety in the world. So as opposed to someone who kind of had a normal sense of safety and then something threw them off, it's kind of easier to get that back than it is to develop a sense of safety when, you never had a good reason to feel it. So in that sense, it's complex. And it can manifest itself in those kind of extra things people experience on top of what I've already emphasized is symptoms. So there can be more extreme emotional repercussions and emotional problems from it. So more extreme mood swings, volatile emotions, going from really sad and crying and overwhelmed to angry and lashing out, really kind of extreme mood swings. It can lead to more behavior. Often there's associated more behavioral problems. So like those mood swings negatively impacting relationships, maybe the person really having trouble maintaining friendships, maintaining romantic relationships, like their relationships being very chaotic and unstable. There's more likely to be, say, substance abuse, which is really common with PTSD in general, because people feel this distress and they're like can't handle it, and they, self-medicate over it with substances. But more so with this complex PTSD entity. And so I'm just checking my notes as I'm going to make sure I'm not skipping anything. And then more somatization, which is just a clinical term for the emotional symptoms manifesting themselves as physical symptoms. And there can be a lot of overlap here, because often people who've dealt with chronic illness will have complex PTSD, so they have actual physical symptoms, but then on top of that, there's the emotional pain also layering on top of creating more physical symptoms. And also just people who've experienced trauma, especially childhood trauma, are known to have more medical problems, like real medical problems. I'm not saying this is in anyone's head, but there is also on top of that this physical manifestation of the pain. And more likely with complex PTSD, do you have these more cognitive difficulties like dissociation, which is where someone feels like they're not there physically. It's if you've experienced it, it's kind of like what it is. It's, wait, I'm not in my body anymore. It's like you feel like you're watching your body from the outside, or you feel like your senses aren't real, like detached from yourself, detached from the world. And also dissociative amnesia. So people not recalling parts of the trauma, like totally blocking it out. And even when they try to remember, like, I just don't remember. Yeah, he came into my room and then it's blank, and so more issues, memory issues, cognitive issues surrounding the trauma itself, or just that can manifest itself in daily life. So now, how does this affect treatment? Well, I'm going to go back to something, but to answer, it doesn't necessarily, with the exception that before exposure therapy is the treatment either way. You really want to get to exposure therapy in order to get the benefit of treatment. However, if someone is using substances, like just so overwhelmed that they're using substances or having extreme emotional trouble regulating their emotions, like things are very chaotic, then you often need to address that stuff first, or at least simultaneous to the exposure. Because when you start doing exposure therapy, you're gonna feel worse before you feel better. So, like, for example, if I'm treating someone who has more complex PTSD or more severe PTSD, we may have to do some work ahead of time so that they feel stable enough to do exposures and not feel like their whole life is gonna derail and make things worse. Now, especially substance abuse is really important to treat, if not first, then at the same time. And the reason is that in order to have exposure therapy work, you have to feel worse when you're doing it. You have to activate the fear structure and kind of feel like you're going through it again when you're doing the exposures. But substances, the whole reason the person's using them is because they block that. They kind of block the emotional pain. So if you're using something that's blocking the emotional pain while you're trying to activate the emotional pain on purpose, it's just not going to be effective, which is why especially things like alcohol are problematic, and really benzodiazepines. So it's hard because benzodiazepines, Ativan, Xanax, Klonopin, people with PTSD feel better when they take them, but you really don't want to be taking that if you have PTSD, because it's like a medication form. I should charge my phone before doing these. And so now there's some controversy here. It used to be said that, the person has to be totally sober before you do prolonged exposure or exposure treatment, but that's just not realistic for a lot of people. They're using the substances because they have PTSD, so now the idea is you treat both at the same time. So that is why it's relevant, is there might be some pre-work that has to be done prior to doing exposures. And but that all being said, the therapist I saw when I did prolonged exposure specialized in a form of prolonged exposure that combines PE, prolonged exposure, with DBT, or dialectical behavioral therapy. Now, if I'm describing complex PTSD and you're like, that's me, you should really look into prolonged PE DBT. And I'm going to, when I post this, link to the site, the organization that does this, that trains people. We can look up provider listings, because and I don't know if I had complex PTSD. There were some things that I identified with, and it was, my trauma was prolonged, but not a childhood thing, thank God. But what PE DBT does better than just prolonged exposure, to the extent where now this is what I do with my patients. I always have some elements of DBT when I'm treating anyone with PTSD, is it better addresses emotions like guilt and shame, because regular prolonged exposure is really focusing on fear. But people who've had traumas have a lot of complicated emotions, especially if you've had childhood abuse. It's impossible, even though it doesn't make sense thinking about it as an adult, it's impossible for a child to learn anything other than, well, I must be deserving this if this is happening to me. That's because that's a level that a child, or even a lot of adults, we think of it. It's like, I remember thinking this for myself when I had cancer, like after 2 years into it, where I'm like, I can't take this. Well, I must deserve this in some way. I can't think of any other logical explanation for why I'm suffering so much. So think especially a child. And so it's better at addressing the guilt, the shame, and helping kind of correct those distorted thoughts of self-blame. And the goal is not just, oh, I don't feel crazy anxious. It's, do I have a sincere internal radical acceptance about this? Which doesn't mean, oh, it was fine. It means that was awful, but it happened to me, and it doesn't define me, and I can move forward. That's radical acceptance in this term. Now, to go back, this is another thing I learned when I did this therapy, and I had been introduced to this DBT-PE. I forget which is first. Is it like DBT-PE or PE-DBT? I will link to this when I put this video up. So really what happens, these symptoms or emotions or behaviors that I describe with complex PTSD just happen to everyone with PTSD. And really what it can be is opposites of extremes on the same continuum that a person flops back and forth between. So for example, let's take behavior. So the same person can go between being extremely avoidant, extremely reserved, extremely inhibited, and then extremely impulsive, like doing things that they wouldn't normally do, like in terms of being reckless, or even things that get misinterpreted as bipolar disorder or manic, like sexually impulsive, spending money, disinhibited, like, hey, like I'm just gonna, why the hell not? And I remember having a conversation with a friend of mine, another cancer survivor, and we were both doctors. We were talking after, like, do you ever notice yourself just like driving unreasonably fast for no reason? Like, just to like, oh, F it, why not? And we're like, yeah, just little things that didn't make sense of, why am I being slightly unsafe in this situation? It's kind of like, we just didn't care. And that is what, regardless of what type of PTSD you have, that's very common. And I found this for myself, just kind of switching, like extremely reserved to like, I'm just gonna, I mean, I say drive fast. I was going 70 miles an hour instead of 60, but not doing anything too crazy, but just things that were, say, a little out of character. It can also be extremes of trustingness, that's not a word, but so anything from not trusting anyone, feeling completely detached, like I just like don't want to see anyone, don't want to talk to anyone, to then switching to being like overly trusting, like oversharing, over vulnerable in situations where maybe you look back and like, why did I do that? I kind of regret that. And I don't mean that like in a judgmental way, oversharing. This is an internal decision of what you're comfortable with. But I mean in a way that's out of character for you, where all of a sudden like, hey, why did I do that? And you're kind of flip-flopping, you're going between these two extremes. So that is just a common part of the experience of post-traumatic stress disorder, but especially complex PTSD. Looking at my notes to make sure I'm not forgetting anything. Okay, now this is what I want to end on, is when some of you will have heard of DBT or dialectical behavioral therapy and be like, no, that's for people with borderline personality disorder. I don't want to do that. Let me correct this. So I have so many patients that were and like you, so borderline personality disorder, I don't know if I can get too much into like the what the diagnosis of it. A lot of you will have already heard of it. It's a really poorly marketed term. I mean, borderline personality disorder, like who wants to have that? It's just the whole way we use the term personality disorders is really unfortunate. I mean, psychiatry needs to remarket that. And so if you're a marketer and you want to help my field of psychiatry do a better job with what we call personality disorders, let me know, or contact the APA. So, but it's forget the thing personality disorder. Personality disorder just means a pervasive, something that's not episodic, like depression, like, oh, I don't feel depressed, now I feel depressed. And, when I'm not depressed, things are pretty normal. It's more of like, oh, for as long as I can remember, I've had this chaos in my relationships. I've had just this chaos in my life. And so it's a more kind of consistent thing from a young age. And so if you think about it, that overlaps a lot with complex PTSD. If you've had a childhood abuse, then you're probably not going to have ever felt, you may not have. I mean, people will have childhood abuse and not have PTSD, so I'm not saying this is a guaranteed thing, but if you're struggling from a childhood trauma, yeah, of course it's going to start from an early age because it happened to you when you were young. So don't let dialectical behavioral therapy, because you heard it's for borderline personality disorder and you don't want that to turn you off. So the therapist I saw who specializes not just in prolonged exposure but also DBT, he told me how he has like Fortune 500 CEOs and just like venture capitalists and all these uber successful people who pay him some crazy amount of money to learn DBT skills, because these are life skills. These are like level up your life skills. And so it's not just, oh, I'm a super dysfunctional person, help me be, less terribly dysfunctional. It's like, how do I evolve and grow? And so the skills that you learn in DBT are emotional regulation. So it's even like, stoicism is really popular right now. It's just like, how do I stay calm when the world is trying to agitate me? How do I reduce how reactive I am? Crisis management. How do I deal with like an extreme crisis, like emotional crisis or situational, where I can keep a level head? It's mindfulness. How do I mindfulness meditation? How do I stay aware and present to not be so reactive? And interpersonal relationship skills. So how do I relate with others in a more effective way? Those are the 4 skills that are taught in DBT. And if you go to a formal DBT program, often there are these very long, extensive programs. It's a year. You go 2 or 3 times a week. There's individual therapy. There's groups. That's like the, level 10 out of 10 DBT, but you don't necessarily need that. It depends on where you're at. It can be really, really helpful, especially if a person's having just trouble functioning in many areas of their life, relationships, jobs, school, things like that. But even just seeing a therapist who's informed in DBT, who could integrate some of those approaches, is really helpful. Marsha Linehan, I will link to this too, founded dialectical behavioral therapy, and there's a really interesting skills workbook that I have that I use with patients. I sometimes use them myself. I'll link to that too, so that's a really great resource. I'm just gonna scan through to see if anyone asked any questions. I don't think so. If anyone wants to type in a question really fast right now, feel free to do that. Let me just see. I'm just in case, to give people a second to type in questions, I'm just going to describe really quickly the difference between the sympathetic and the parasympathetic nervous system, because parasympathetic, fight or flight, bear in the woods, I gotta escape, that is separate from the parasympathetic nervous system, which is really the opposite. It's the, you have fight or flight, parasympathetic is rest or digest. So in order to have like an even state of being, you both need to learn how to take the foot off the gas, which is the sympathetic, but put your foot on the brake, which is the parasympathetic. Because what happens in people who have a lot of anxiety and or PTSD is that their gas pedal is always on and their brake pedal is always off. And so it's not just enough to take off the gas. You need to learn how to actively relax. And that's why another crucial part of any kind of PTSD treatment, along with exposure therapy and these other tools I'm mentioning, is training yourself in relaxation. Breathing exercises. Breathing is really important, and it just sounds so like faddish. Oh yeah, I read to do a breathing exercise. No, this is a real thing, because your breathing is both consciously controlled by muscles surrounding your rib cage, your intercostal muscles, but it's in your diaphragm. You can consciously control your diaphragm, but your diaphragm is also innervated, controlled by a nerve coming from the brainstem called the vagus nerve, which is under unconscious control. It's part of your parasympathetic nervous system. So when it comes out of your brainstem, it travels along the back of your thorax, and then it goes to your diaphragm. And when you breathe, oh gosh, is it the back of your thorax? I probably made a mistake. I'm trying to remember my gross anatomy. So forgive me if I made a mistake there, exactly what the pathway is. But when you breathe deeply, you're stimulating it. So you can choose to consciously breathe deeply, and you're stimulating this nerve and you're increasing its activity. And so you have, it's like exercise. The first time you do it, you're like, I feel a little bit more relaxed. but you're not lifting 200 pounds, on your deadlift on day one. You work your way up and then you get better at using it. So simultaneously as doing exposures, you're doing relaxation practices. So, okay, so I don't think I got any questions, which is no problem, you guys. Anyone who has a question can email me or like post it on this video when it goes live, and I can follow up next week. Next week, you guys are gonna like. It's gonna be same time, 5:30 Pacific time on Tuesday. I will be talking about psychedelics and MDMA for PTSD, and I will be sharing my personal experience using psychedelics for my own PTSD, the protocol I used. And if you work for the DEA, this is a joke. It's a fictional story. I didn't really do this. I don't think I winked so well right there, but so stay tuned for next week. You guys will like that. I'll see you then. Bye.